Okay, so we'll move on to our next topic, which is dengue vaccine with talks from Dr. Atmar, Esquilin, Hambach, and Waterman. So we'll begin. Dr. Atmar, please.
Thank you and good morning. So first want to acknowledge the members of the work group. The ACIP members include Dr. Bell, Ms. McNally, and Dr. Paling. Want to acknowledge our CDC co-leads, Steve Waterman, who will be speaking later in the session, and Gabriela Paz-Bailey. Thanks to the ex officio members, liaison representatives, consultants, and other CDC contributors to the efforts ongoing in this work group. So this slide depicts some of the work group discussions we've had since our last meeting. It includes the dengue vaccination, a review of dengue vaccination in the Philippines and some of the unintended consequences, review with the work group of our October ACIP presentation and the discussion that occurred during that session. We took an informal poll that Dr. Waterman will tell you a little bit more about later in the session of work group members to address some of the needs that we need to address before we can make decisions about recommendations. We reviewed the CYD 65, which is a follow-up study of Dengvaxia efficacy. Looked at partnership for dengue control, pre-vaccination screening, workshop that reviewed that with the work group. And then we reviewed Puerto Rican dengue vaccine knowledge and attitudes. The presentations then today, Dr. Esquilin will review dengue vaccine knowledge and attitudes in Puerto Rico that I just mentioned. Dr. Hambach will give us a perspective from the WHO standpoint on recommendations for dengue vaccination. And then Dr. Waterman will close the session with some of the deliberations of the work group and review of next steps. So this is our anticipated schedule. In June, we hope to present CDC assessment of the laboratory tests for pre-vaccination screening, which is one of the needs, and then the possible additional cost effectiveness presentation with the idea in October, we may be able to review the evidence to recommendations framework and possible draft recommendations. And I think that's it. Dr. Esquilin, thank you.
Good morning. I will be presenting the dengue vaccine knowledge and attitudes data from Puerto Rico. The information was obtained from 3 different sources: the general population, physicians, which were mostly pediatricians, and from parents of children between the ages of 9 to 16 years of age. The general population data comes from a household survey done in southern Puerto Rico. The physician data was gathered from a survey sponsored by the Puerto Rico Academy of Pediatrics. The opinion of parents of children between ages 9 to 16 comes from focus groups conducted by the behavioral science team of the dengue branch in San Juan. The general population data was obtained from a community-based cohort study implemented in 2018 known as COPA. The participants were recruited from selected households in 38 cluster areas. A total of 1,139 adults participated in COPA. When asked if they would receive the dengue vaccine for free, 73% said they will receive it for themselves, and 75% will administer it to their children when asked. They also said that they will pay for the vaccine 62% said that they will pay for the vaccine for themselves, and 68% will pay for the vaccine for their children. When the interest in dengue vaccine among the adult participants was explored, 59% will pay $10 per dose of the dengue vaccine, 37% will pay $20, and 12% will pay up to $50 for the vaccine. When they were asked for the reasons for not wanting the vaccine or for being unsure about it, only 1% were not worried about getting the disease. There was a lack of information about the vaccine, since 22% of the participants could not state a reason and 9% needed more information. 38% of the participants were worried about the adverse reactions. When they were asked about the most important feature of a dengue vaccine, most participants were concerned about the high level of protection. Concern about minimal side effects was more common in participants that were unsure or not willing to receive the vaccine. Now we will discuss a physician survey that was done among physicians in Puerto Rico. 102 physicians completed the survey, and 81 were either pediatricians or pediatricians with a subspecialty. In terms of the methodology, a pediatrician from the CDC dengue branch gave presentations to the local pediatric associations during the fall and winter continuing education meetings from September to February of this year. Physicians were asked to complete the survey after the presentation. The survey included an informational paragraph on the risk of hospitalization and severe illness in vaccinated seronegatives, and on the implications of a pre-vaccination test specificity. Additional surveys were provided to pediatricians in the San Juan metropolitan area and from the University of Puerto Rico School of Medicine. The Department of Pediatrics provided with a copy of the CDC presentation, published literature on the vaccine, and on available laboratory tests for pre-vaccination screening. The results were as follows. Only 31% of physicians administer vaccines at their offices. Most of the vaccines are administered at private or public immunization clinics in the island. And 98% of participants acknowledge that dengue is a significant public health problem in Puerto Rico. Only 58% of physicians knew that there was an FDA-approved dengue vaccine. 40% of the physicians knew that the schedule requires 3 doses, and 48% didn't know. Only half of the physicians answered the question on the efficacy of the vaccine, and 54% stated that they don't know what is the approximate efficacy. The answer to the question of what percent of false positive tests they were willing to accept was distributed between 0 to 5% of false positive for 54% of the physicians, and 35% were not sure. Assuming a laboratory test with acceptable specificity were available, 73% of physicians would recommend the vaccine and 21% were unsure. Of those who will recommend the vaccine, 96% think that dengue is an important public health problem in Puerto Rico and that a reasonably effective vaccine is available for seropositive persons. A 40% think that the laboratory testing reduces the possibility of vaccinating subjects with a false positive lab result. Of those unsure or not wanting to recommend the vaccine to their pediatric patients, 71% had concerns about the risk of vaccinating persons with a false positive dengue lab result, and 75% needed more information. For patients diagnosed with dengue, a 43% of physicians have documentation of a positive lab test in the medical record for some of their patients, and only 5% for all of their patients. Physicians establish that the necessary steps to enable a vaccination program for children in Puerto Rico include BFC and private insurance coverage for the vaccine and insurance coverage for the laboratory test for detection of past dengue infection. A 54% of physicians will recommend the vaccine even if insurance coverage for the vaccine and the lab tests were not available, but 30% were unsure. If a recommended rapid test for past dengue infection were available, 66% of physicians will support changes in the Puerto Rico laboratory regulations. This is to allow such a test to be performed in the medical office so that the first dengue vaccination will not require 2 or more patient visits. Most will favor a pilot project with phased approach of dengue vaccination before implementing a large-scale program in the island. Now we'll represent the data obtained from the focus groups with parents of children between 9 to 16 years of age. A total of 38 participants were involved in the focus groups, of which 87% were mothers. The objectives of the focus groups were to assess acceptability to the vaccine, determine barriers to and motivators for a dengue vaccination program, and to identify knowledge, attitudes, and beliefs toward vaccines. In terms of the methods, focus group discussions were done in 3 municipalities with a high dengue incidence. That was in San Juan, Carolina, and Ponce. The sample were parents of children between 9 and 16 years, and they were recruited from the pediatrician offices, the WIC program, schools, and the Boys and Girls Club of Puerto Rico. It is important to mention that 63% of those parents had at least 1 year of college education, and 1/3 had completed a college degree, either a bachelor degree or a master's degree. Previous to asking the questions, a script was read with information about the dengue vaccine, and doubts about the script were clarified to the participants. In terms of general opinion about vaccines, most participants had questions about having a dengue vaccine. They have positive opinions about vaccines in general, but some of them decided not to receive the flu vaccines and were concerned about issues like that the flu vaccine changes every year, and some concerns about efficacy. Also, they distrust some of the new vaccines, and others had concerns of allergic reactions and autism as a result of vaccination. In terms of opinions about dengue vaccine, most participants have questions, and a few had mixed opinions about this vaccine. Some will wait to see the effects of the vaccine on other children, and others do not find necessary to have a dengue vaccine at this moment. Almost all participants did not know about the dengue vaccine. In terms of willingness to vaccinate, 38% will vaccinate, 30% answer no, and 32% were unsure. The barriers to vaccine program participation identified within this group included lack or inconsistent information, high cost or lack of insurance coverage, a time-consuming lab test, side effects of the vaccine, laboratory test results that might not be 100% reliable, approval for use of this vaccine only in U.S. territories, sickness at the time of vaccination, and probable low effectiveness of the vaccine. The motivators for vaccine program participation identified included provision of correct vaccine information, information about dengue and statistics in Puerto Rico, prevention of future dengue infections, support from the Puerto Rico Health Department, lab confirmation of prior dengue infection, the event of an epidemic, and educational forums. Most participants will pay a deductible for the vaccine. Obviously, they will prefer it at no cost. An acceptable insurance deductible for participants will be somewhere between $5 and $20, and an acceptable cost without insurance will be around $50 to $80. All participants wanted more information about Dengvaxia and about the test to confirm past dengue infection. They have multiple questions, including why the vaccine is specific for children between 9 to 16 years of age. Where have clinical trials have taken place and what were the results? What does the process of approval involve and how long does it take? What type of vaccine is Dengvaxia and what are the components? What is the dosage and how many times it has to be administered? What is the percentage of effectiveness? They wanted evidence on short-term and long-term side effects and how to treat those side effects. Are there any possible interactions with previous medical conditions or medications? How does the vaccine react if people get vaccinated and later have dengue again? What countries are using the vaccine? Why it is approved for U.S. territories only and not for the mainland? Does the Puerto Rico Health Department requires the vaccine? And finally, what dengue tests are required and how accurate those lab tests are. Participants stated that a culturally appropriate informed concern should include information about vaccine safety and effectiveness, specific laboratory test requirements prior to vaccination, specific consequences if vaccinated without a previous dengue infection. They wanted it to include benefits and risks of vaccination, specific short-term and long-term side effects of the vaccine, results from previous clinical trial studies with number of participants in the trials and percentage of effectiveness. And they wanted the information related to the consent form to be written in a plain language, clear and concise. They all recognize that the best source of information will include doctors, specifically pediatricians, nurses, the School of Medicine, the Academy, the University of Puerto Rico School of Medicine, at the Medical Sciences campus, and the CDC. In conclusion, what did we got from all those groups, first from the general population, we can say that adult participants demonstrated interest in the dengue vaccine for themselves and for their children. The side effects and possible adverse reactions were the most important reason for those not wanting to receive the dengue vaccine. Among adult participants willing to receive the dengue vaccine, a high level of protection and minimal side effects were the most important features. From the physician's knowledge and attitudes survey, we can conclude that most participants were pediatricians, but only 30% administered vaccines at their offices. Most vaccines are administered at public or private immunization clinics. Almost all physicians recognize that dengue is a significant public health problem in Puerto Rico, but 43% were not aware that there is an approved FDA dengue vaccine. Further physician education is needed regarding Dengvaxia vaccine, its schedule, efficacy, and safety. Most physicians will recommend the vaccine if a laboratory test with acceptable specificity were available to document prior dengue infection. Medical record documentation of past positive dengue laboratory diagnostic test for patients is limited in the island. Most physicians view that the necessary steps to establish a vaccination program in Puerto Rico include BFC and private insurance company coverage for the vaccine, but also for the laboratory test. And from the parental acceptability focus groups, we can conclude that most parents will agree to vaccinate their children if they have information on Dengvaxia. The most important barrier for parental consent to vaccinate with the vaccine is lack of detailed information. The most important motivators are having information about the vaccine effectiveness, side effects, the rationale for use in Puerto Rico and current use in other countries, having support of the University of Puerto Rico, the Puerto Rico Health Department, and the CDC, and the disease prevention impact of the vaccine. And the most important influencers will be the pediatricians and the family. Thank you.
Thank you very much for that presentation, Dr. Esquilin. I'll take chairperson's prerogative and ask the first question. So, since only 31% of vaccines are administered in the physician's office, where are the other 69% administered?
Those vaccines are administered at either private or public immunization clinics in the island. The vaccines that are provided by the BFC program are given to the patients in clinics that are run by the Puerto Rico Health Department. But those patients that have medical insurance can get their vaccines from private clinics established in different private hospitals in the island.
Thank you. Dr. Szilagyi.
Yeah, thanks for that information. And honestly, I think a lot of this confirms other studies of providers and patients that there's general interest in vaccines, but that these practical feasibility issues can really either facilitate or get in the way. One question I had is, what is the level of insurance coverage for the laboratory test or for the vaccines beyond VFC in Puerto Rico?
I'm sorry, what is the interest?
What is the cost of the laboratory and how much insurance coverage? What percentage of children, for example, would be covered for the laboratory test?
We don't have that information yet. We need to have the lab test approved and then submitted to the insurance companies to see if they will approve it. We still don't know.
And do the public health clinics do the laboratory test, or would that have to be done in?
It has to be done at a laboratory because in Puerto Rico we have regulations that establish that we cannot do any lab testing in the office or in a clinic. It has to be done by a lab technician. And it's a specific regulation in the island. We haven't been able to do even HIV rapid tests in the labor room. It has to be done by a lab technician in the lab.
So may I ask the question more pointedly? So there is no point of care testing
No,
in Puerto Rico?
no,
Okay.
no.
Thank you. Dr. Bernstein.
It sounds like pediatricians would be a large influence on acceptance of this vaccine and providing the important information that's necessary. Are they staffing the health centers that are administering the 69, to 69% of the children? Are they pediatricians or other child health professionals? Because if the pediatricians, they're not going to see pediatricians, it's hard for them to be an influencer.
Well, the pediatricians are not physically at the immunization clinics. We will depend, and we are depending on the information provided by the nurses on site. The pediatrician will see the patients in their offices and will recommend the vaccine, but most patients will still have to go to the immunization clinics to get the vaccine, and then they will get additional information from the nurses and the consent from the immunization clinic nurse.
So it's an additional step in
Yeah.
order to, and then adding a laboratory test requirement adds additional tests.
The pediatrician will be the one recommending and ordering the lab test. Then the pediatrician will have to see the result and then approve the administration of the dengue vaccine. That's how it will work.
Dr. Atmar.
Yeah, I mean, one of the issues that the work group is struggling with, and I think this committee has also struggled with based on previous presentations, is the logistical nightmare of having to go through the additional step of getting the testing done, which I also understand is so the child shows up to the pediatrician's office, consider for vaccination, then they have to go to the laboratory to get the testing done, then someone has to evaluate the result, presumably the pediatrician, and then send to the public health clinic to get the vaccine. And so while the vaccine may be a benefit to the child, the logistics of doing that and then the additional concern of paying for the cost of the laboratory test, which is not covered through VFC, is one of the things. And I think when Dr. Waterman gives his presentation at the end of the session, we'll review some of these logistical considerations. And one of the things that, that's a major concern. One of the possibilities would get a point of care test, but it would require a change in the law, essentially, to allow that point of care test to be done in the doctor's office, assuming a sensitive and specific point of care test could even be developed, which is something else that Dr. Waterman will address.
Is there a reasonably robust electronic health record, or did the difficulties with the hurricanes or whatever kind of wipe out that option?
Well, for most of the hospitals in the island and the private pediatric offices, there's no electronic record. In the main academic center in San Juan, we just implemented the electronic record 3 months ago. So that's a major difficulty also for getting the results of the labs available, because if we don't have an electronic record available, patients will have to come back and bring the result. And if we want to know about past dengue infection, it's somehow a little bit difficult to get the result. We have to make sure that it is filed in the paper medical record in the physician's office.
Dr. Hunter.
I just wanted to say, as a clinician and as a medical advisor to a local health department, this analysis is really sets the standard, I think, for future similar analyses for the purposes of our voting on the ACIP when there are so complicated implementation issues. I think the three groups you picked were very appropriate. I think the questions you asked were right on track of what we need to know in public health and in clinical practice. And I think that the speed in which you did it and the size of the samples were appropriate for how fast we need to know this. And you didn't get bogged down in the details. So I just want to say you did a terrific job and you really set the standard for what we should look at in the future.
Thank you.
Dr. Lee?
I echo my thanks. And also, two questions that either you can answer or maybe some of our liaisons could answer. One is there an electronic immunization registry available? And if so, is it possible to kind of amend it to enable lab testing to be part of the record? And then I'll ask a second question after.
That's a very good question. We do have an electronic immunization record created through Vaccines for Children, but available to all the population, even from private clinics. So we do have that, and we're gonna work to change that registry to include the dengue vaccine and probably the lab result too. So if a patient goes to a different clinic, they can find easily that that patient had the test done and qualifies to receive a first, second, or third dose of the vaccine.
My second question, and it may be a straightforward answer, is just thinking about the Vaccine Injury Compensation Fund, and if there were any adverse effects, would these children potentially be eligible if there were something life-sustaining?
Dr. Goldman?
Thank you, Jason Goldman, American College of Physicians. Thank you for this work and this study. It really does open up a lot of possibilities, I'm thinking, in South Florida as well, because we do have a very large area of the population from Puerto Rico and where I am in South Florida. So it would be interesting to see, expanding this kind of work to see if there is any role for it for those who are not currently living in Puerto Rico but who have moved to South Florida. And to answer the question Dr. Lee posed about the registry, Florida does have a registry, but the problem we see is, of course, the implementation and everyone using it, because while we do have electronic records, not everyone is fully integrated with the state registry. But, and as to answer the question about point-of-care testing, I haven't seen it, but I have tested for dengue antibodies for patients of mine who have come in and traveled, had symptoms, and have had, of course, positive, negative results. So with the local labs, the national labs, we can certainly do those testings, get the results, and communicate with the patients. But it would be interesting to see some integration with the state shot registry and be able to get those laboratory data. That would be very helpful. So it might be also interesting to expand to Florida and see if there's any need for it in the South Florida area as well.
Mm-hmm. Thank you.
Dr. Coyle, please.
Hi there. I just wanted to respond to the use of an electronic immunization registry in this type of situation. So it's one thing to have an indicator indicating that you have a positive result or a negative result. It's a different issue altogether to incorporate lab results into an electronic immunization registry. So I think those are the considerations that need to be put in place. And then you have to consider the interoperability between an EHR and an IIS as well. So these are big shifts in the way that we've typically done this. And I think that is absolutely a consideration that needs to be thought about. It's not impossible, it just is not typical today.
It's difficult, but we hope we can do it.
Are there any other questions, comments? Dr. O'Leary.
Yeah, thank you again as well for that great presentation. I just wanted to ask a quick question. In one of your earlier slides, you presented data among the people that didn't get the vaccine, or that said they wouldn't want to get the vaccine, that 17% said they didn't believe in vaccines. Is that kind of a general representation of, is that common in that level of vaccine confidence in Puerto Rico?
No. We have a high percentage of vaccination in Puerto Rico for most of the vaccines. What has helped us significantly is incorporating vaccines as a requisite to enter school for school-age children. The acceptability of vaccines in the island is actually very good, but as everywhere, we have groups that are against vaccines, are not willing to vaccinate their children.
Dr. Waterman, if you please.
Yeah, just to clarify that 17% is 17% of those who didn't want to use the vaccine. So in terms of the total surveyed population, it was like 3% or something, very low, much lower number.
Thank you for that clarification. Any other comments or questions? All right, very good. Thank you very much.
Thank you.
Our next presentation will come from Dr. Hambach, please.
Good morning, everybody, and thanks very much for the invitation to speak here on WHO's position on dengue vaccination. What I'm going to do here in the next 15 or 20 minutes is I'll give you the rationale on the WHO's position on vaccination, also how it has evolved, because I think it's important to understand this. And then obviously what you're very interested in is to talk a little bit about implementation issues. But as you know very well, this vaccine has been only used in 2 very limited public programs. So the experience overall is not large, but obviously we can draw also from experience from other vaccines. So WHO's mandate is to advise countries on the use of vaccines against diseases of public health importance. And the first generation dengue vaccine, Dengvaxia, was licensed initially end of 2015 and then in 2016 in a number of endemic countries. And so WHO issued in 2016 its first position on dengue vaccination. But before going into this, let me just remind you again, what you probably all know, that dengue is really a global public health priority. In 2019, WHO had listed it among the 10 biggest public health threats. That was certainly done with the perspective that we have an environment that is extremely favorable to further transmission and to further spread of dengue. And this is combined with the situation that we have very little tools, apart from vector environmental management and vector control, which, as we all know, is very difficult and very difficult to scale. So the need for a vaccine is really extremely important, and we are unfortunately still in a situation that we have a vaccine that is not very easy to implement. Dengue is not a high mortality disease if it's well managed. It's a morbidity disease, but it causes a lot of fear among populations. It causes a lot of strain to the health system, and it can actually also have quite considerable economic cost. And I think the survey that we have just seen before shows that there is a high awareness around dengue. I'm not going to go into detail of the first generation vaccine, Dengvaxia or CYD-TDV. I think you've seen this before. Just want to show you here in terms of the time scale of the 2 pivotal studies that were used for licensure of the vaccine. CYD-14, that was in Asia, and CYD-15 in Latin America, with overlapping age groups. Asia was 2 to 4, and Latin America was 9 to 16 years of age. WHO's position in 2016 took into account data that became available up to around month 48. And these were the most important original licensure data. Again, I'm not going to go through those in detail, but I think it's important to underline that while the efficacy against symptomatic dengue was, call it moderate, the efficacy against hospitalized dengue and severe dengue was actually very high. And so that is something that really needs to be kept in mind. This vaccine has been performing very well against the more severe forms of the disease. The issue that, of course, occurred, which you all know, is that in the 3rd year after the start of the trial. In the most youngest group, there was a safety signal that occurred, that there was an imbalance and increase of severe and hospitalized dengue. And at that point in time, essentially the evidence is what was causing this were not entirely conclusive. And while there was, of course, a strong suspicion that it was tied and linked to serostatus, the way the trial was set up didn't allow to come to a definitive conclusion on this. In our first position, we actually used a lot of kind of supportive work that was done through mathematical modeling. So we convened 8 mathematical modeling groups that essentially assessed the impact of the vaccine in different transmission settings. And the way, so to say, how these models assumed that the vaccine would work is basically shown here. This is, I think, now all pretty well known. It's essentially assumed that the vaccination acts like a primary silent infection, which then brings the person, if the person was naive at the time point of vaccination, brings it into this situation where there is an increased susceptibility to disease with a secondary infection, and thereafter the person should be, so to say, in the post-secondary low disease risk phase. If the person had already a single infection, the vaccination would move it to some extent to the to the post-secondary phase, and that's where you would see protection. These data fitted most. This model structure fitted most nicely, actually, the empiric data that were collected from the vaccine trial. So WHO's position in 2016, and I'm not going to show it to you because we have modified it afterwards, was essentially a position that was informed by, obviously, the trial data and also extensively informed by a mathematical modeling. And it was a position of risk minimization in populations with a highly conditional statement that basically population-based recommendation should be done only if the seroprevalence in the target population is high, and the models predicted the highest effectiveness actually if you were in the range of 70% seroprevalence at 9 years of age. And there was a recommendation against using the vaccine in lower seroprevalence setting. So what WHO also did is, when we issued the recommendation, is we issued a very strong call for the company or the global community to gather more data on the performance of the vaccine, to understand really the root causes of the safety signal, and to be more specific than in terms of risk minimization or risk or avoidance of risk when using this vaccine. And then obviously the company came about 2 years later with an additional retrospective analysis. And I have to say, when we issued the first position, nobody actually knew that this was possible at that point in time to do such a type of retrospective analysis that indirectly estimated what was the serostatus at baseline before the administration of the first dose. So these data came out around month 66. These were the data which we all know that created in the countries, and particularly in the Philippines, that started to use the vaccine already in 2016, a major outcry. And this study was published here in this New England journal. They used 3 different methods to assess serostatus as baseline. I'm not going into detail of these methods. I think important to note is in particular the serological assay, NS1 assay, that allows to make a differentiation to understand if the NS1 antibodies are actually derived from the vaccine, which has a yellow fever component, or from natural infection. And then 2 statistical models were also used independent models were used to impute the serostatus as baseline, and all gave pretty similar results. So this is just a snapshot in terms of the relative risk. And what I show here, which I think is an important slide, it shows you the age group for which the vaccine was licensed, 9 to 16 years of age, and over the full duration of the follow-up of these 66 months at that point in time. And what it actually, first of all, shows that there is a continued and reasonably robust protection against hospitalized and severe illness in seropositive individuals, but that obviously the risk ratio or the hazard ratio looks not favorable in the seronegatives. And if you take other figures where you also include the younger age groups, this ratio becomes even less favorable. So that figure, while it to some extent did corroborate what was in the mathematical models and also quantitatively very much fitted with the mathematical models, created a major a crisis in the sense that obviously now we were in a situation that we could essentially describe and say which individuals would not be benefiting from the vaccine or would actually be put at risk. And so that obviously then also required that we had for us to reconsider our position, which we swiftly did. And basically you could think of, in terms of risk minimization in seronegatives, you can still think of in principle of two approaches. The one is still the population seroprevalence criteria without screening, maybe with some tweaking in terms of what seroprevalence level you would like to accept as the minimum level. And then obviously, and this is also the way the label has been changed, the individual pre-screening before vaccination. Both have major implications, both have come with major problems. As we also know, there is no really validated rapid diagnostic test at this time available for past infection. But as we also know, there's a lot of work going on into this. When we developed and SAGE developed the policy, they looked at a number of dimensions, the benefits and harms dimension, also the dimension of coverage. And it's actually quite interesting because if you think of seroprevalence and if you have to go to areas where you have very high seroprevalence, there's actually not that many populations where you have this high prevalence. And you will need to do extensive seroprevalence surveys, which are very costly also and tedious to do. There are clearly ethical considerations that are very, very important in this context. And you have the issue of harm of omission versus harm of commission, and there has been a lot of discussions around this. Risk perception communication, extremely important. We had the Dengvaxia crisis in the Philippines going on. And then a lot of practical aspects in terms of feasibility, test limitations, cost, implementation challenges, and so forth. And on balance, without going into the detail, I think on balance there was a very clear statement that this vaccine should only be used with individual pre-screening, individual level pre-screening prior to vaccination, even though we left the door a little bit open for seroprevalence-based use of the vaccine. So the position, you probably have read it, is here. It's very clear. The vaccine should only be used if there is really a risk minimization strategy that you can put in place. Pre-vaccination screening is the way to proceed according to our understanding. The screening tests that's of course quite a challenge because you need high specificity to avoid vaccinating seronegatives, but you also need a robust and high sensitivity to assure that the seropositives are really being vaccinated. And obviously, there is a lot of work to be done and is going on in order to validate rapid diagnostic tests. And as I will say in a minute, obviously, the performance of the test depends on the epidemiological setting. So it requires a very careful assessment. The age group for vaccination is also relatively tricky, and I'll show you a slide on this. It depends on the transmission intensity, but it depends obviously also on operational and programmatic considerations. From an epidemiological and understanding of the vaccine performance point of view, the optimal age group is the one where the most individuals have monotypic infection, and that would be essentially the age before you would see the peak of severe disease as a proxy. And so, as I said, we left the door open for a population-wide use of the vaccine with very high seroprevalence, even though we think it's basically not feasible. And most important is a full disclosure and communication around with this vaccine in relation to individuals with unknown serostatus, but also communication around the risks that come from false positives if pre-screening with rapid diagnostic test is being used. There is a number of implementation considerations. I think it's very important to understand the local burden of disease, the age distribution, so that you know which group is actually best to target. The rapid diagnostic test must be assessed in the context of the specific epidemiological setting. We haven't gone into affordability and cost effectiveness, but it's clear that besides the vaccine, you will have the cost of the test and you will have the cost for the program operations. And the program operations cost can be quite significant. We know this from other vaccines. We know this from, for instance, from HPV delivered at school. This is a relatively important cost factor that needs to be really put into the equation. Implementation strategies obviously depend on the age group chosen. I think there's probably might be a strong interest in school-based vaccination. And you need to have the necessary follow-up and record keeping. And I think we had just a discussion about electronic records, certainly something which is extremely helpful to do follow-up. And then obviously we have the communication issues, and overall, of course, as for any vaccine, you need to look into the local priorities in relation to other alternative investments. Extremely important is to highlight that this is a vaccine that is partially effective, which means vector control needs to continue. Clinical management needs to keep at high level, and so forth. So these are all very important issues that need to be considered. Just a few more details. So in relation to really the target age for vaccination, I mentioned this already. According to the way the vaccine works, you aim at optimizing, at targeting the group where you have the highest proportion of monotypic seroprevalence. And this depends on the force of infection. And so it depends on really how the transmission intensity is. If you go to higher seroprevalent settings, you will have the peak earlier and you will have a more distinct peak. And you will also have less seronegative. So there is, even though with a pre-screening approach, you have more flexibility in terms of which transmission settings do you go, it is certainly more effective and also more cost effective if you go into settings that have pretty high burden of dengue. The diagnostic tests are an area of active research, and I'm not going to go here into the details. As I said already several times, you need the positive predictive value. Negative predictive value depends obviously on the seroprevalence, and so you need to look at this in the context of the epidemiological setting. There is a group, GDAC, that has done some surveys and interviews both in Asia and Latin America in terms of acceptable level of sensitivity and specificity for rapid diagnostic tests. So there is some information out there, but I think this is also something that needs to be brought into the equation if you consider really implementing this vaccine. I want to say 2-3 words around communication, and I'm sure you have all seen this. This is from Heidi Larsen's Vaccines Confidence Project, where she had surveyed the confidence into vaccines in general, vaccination in the Philippines, and then did this survey again after the Dengvaxia crisis. And what you obviously see here, without going into detail, is that strong confidence in a vaccine was completely shattered with this crisis, and with now a very strong proportion of the population that has a tendency to disagree with the importance and also with the safety of the vaccine. And as you know very well, this led to a drop in vaccination coverage in general. It provoked measles outbreaks, polio. So the repercussions for an immunization program can be dramatic, as the Philippines situation has shown, if the communication is not properly handled. There was an attempt, I mean, this program in the Philippines was essentially abandoned after 800,000 doses had been administered. And to my knowledge, there is no really follow-up evaluation being done. So you have kids who got 3 doses, kids who got 2 doses, kids who got 1 dose. What some colleagues of mine did was essentially an estimation in terms of the proportion of trying to understand what would be the proportion of vaccine-induced cases of dengue in relation to those that are being prevented through the use of the vaccine. And this was based on the data from the clinical trial, which they had the clinical trial from Sanofi had a big subgroup in the Philippines. And with the assumption you see here of the seroprevalence and the performance of the vaccine, it was estimated that, as you see here, that you avert about 18 dengue hospitalizations among seropositives for 1 precipitated hospitalization in dengue-naive vaccinees and 10 to 1 in relation to severe disease. So the overall performance of the vaccine is most likely, from our understanding, would be positive, but it hasn't even been assessed. And things have just been left in limbo, which is, I think, very unfortunate, and both for the population, but overall, both for understanding of that vaccine. So in terms of communication, I think what was presented already before is, I think, really the way to go. And what is absolutely important is that there is tailored and targeted communication, and the communication must be proactive. The communication must happen before a program is being put in place. And this is what our communications specialists tell us. You need, once a perception has been formed on a vaccine, it's very difficult to change it. So it is very important to convey the facts and figures ahead. And so this is something which is absolutely essential. And there is many things that need to be communicated about this vaccine because it is very complicated. The risks and benefits, the rationale for the pre-screening, the issue of vaccinating seronegatives, but also the issue of sending home people who are actually seropositive but have tested negative. Obviously, the issue, what we have for other vaccines as well, of partial effectiveness, the complexity of the schedule, and then also an honest discussion in terms of where we are of duration of immunity and booster needs, which, as we know, is still something that is under investigation. And all this needs to be communicated, as I said, in a proactive manner. The strategy needs to be segmented into the various audiences. And last not least, communication must be both ways. So there must be really opportunities for dialogue. And again, we have seen a first attempt to understand what people need to know and what people want to know and what people's wishes and perspectives are. I think this concludes my presentation. We have a disease of very high public health priority where we unfortunately still don't have a perfect vaccine. The current vaccine has potential, but it has significant shortcomings which come with a complex implementation challenge. And again, I think what is really important is that surveillance, vector control, environmental management, and case management need to be emphasized in a dengue endemic setting, irrespective of if you go ahead with a vaccination program. Thank you.
Thank you very much for that presentation. Questions? Comments? Yes, Dr. Peeling.
All right, thank you for sharing the experience and what you guys have learned from the Philippines. That was very helpful. I'm going back to slide 18 where you went into the estimation. I'm assuming that those estimations were for the entire population because you hadn't learned about the younger kids. And have you split up the estimation of those prevented to those precipitated by age group for the kids 9 to 16 in particular?
Is it this slide here? Because
Yes, that's
I don't
the
see the
one,
numbers.
yes.
Okay. So this is really done from the randomized control trial. So it was age 9 to 16. It's the age group 9 to 16. I think the big assumption is here is whether the vaccine performs the same if you give 1 dose, 2 doses, or 3 doses, which we of course don't know. So we had to assume that it works as for 3 doses.
Are there any more comments or questions? Yes, Dr. Lee.
Always good for a comment. Thank you so much for the presentation. It was actually incredibly helpful to hear your experience around decision-making and what went into your decisions. It's more of a comment than a question, but like I found it really interesting, partly because I'm realizing that in a way, the way you frame this is the way we think about value in healthcare in general. And one of the things, in addition to considering population benefits, population risks, as well as individual benefits and risks, is that like the way you're evaluating the impact of your recommendation and subsequent implementation also takes into consideration the impact on providers and patients. And I was particularly struck by that vaccine confidence slide. I thought that was really interesting and a good way for us to think about the impact of our recommendations and how we make them and how we communicate them can really make a huge difference in our public health efforts to really help the population. So thank you for that. I thought that was really useful.
Thanks.
Any more comments, questions? All right, if none, then we'll move on to our next topic, which is Dr. Waterman, please.
Go back. Is it not working? Where do I? Okay, well, that's my second slide, but we'll get started. Good morning. So I'm going to summarize the dengue vaccine work group's latest considerations. And as Dr. Atmar mentioned, and as I'll elaborate, the work group does not expect to make recommendations until an independent evaluation of the specificity of available laboratory tests for past dengue infections is available for presentation to ACIP. And this contingency makes likely that the work group would not make preliminary recommendations until the October ACIP meeting at the earliest. So I just want to summarize what I thought the work group considered the key points and take-homes from Dr. Escalin's presentation on community, pediatrician, and parent knowledge and sentiments about Dengvaxia in Puerto Rico. First, 73% of pediatricians would use Dengvaxia given an acceptable pre-vaccination screening laboratory test. The majority of pediatricians would like to see a screening test with the specificity of at least 95% at least, and preferably 99%. 76% of pediatricians supported a pilot project, and I'll talk a little bit more about that in a second. Over 80% of pediatricians felt that vaccine and lab insurance coverage were necessary steps for implementation. Clearly, parents and physicians need more education about the vaccine. And there's a need to explain the rationale for vaccinating in dengue-endemic areas such as Puerto Rico. And there were relatively few negative perceptions about the vaccine in the surveys that were conducted. So the dengue vaccine work group conducted an informal poll of its formal members last December. And the work group members were asked to comment on what information is needed to make a recommendation on Dengvaxia. By far, the biggest and most often mentioned concern was having an acceptably specific vaccination screening laboratory test for past dengue infection. in the sense that we do not have enough information about available tests, and I think Dr. Hombach referred to that. The logistical challenges of pre-vaccination screening and the cost of laboratory tests were also frequently mentioned. I think Dr. Hombach's presentation echoes workgroup concerns about transparency, transparency with regard to communication and the importance of clear community engagement to avoid unintended consequences. A number of workgroup members felt that a pilot vaccination program could be implemented in children with documentation of previous dengue infection in the medical record, and Dr. Escalin's presentation on the Puerto Rico survey suggests support for such an approach among Puerto Rico pediatricians. A pilot vaccination program might enable logistical issues to be worked on and solved. With regard to a pilot, one workgroup member commented that an anticipatory recommendation would allow for insurance coverage for the lab test to be put in place as testing technology improved, and argued for the advantage of having a recommendation in place in advance of possible dengue outbreaks. A number of workgroup members expressed skepticism about a shared decision-making recommendation. Comments included that shared decision-making passes off the decision-making to the clinician, and that such decision-making would be complex and could depend on the level of education of the family. So the CDC dengue branch is in the process of evaluating available and newly developed dengue IgG laboratory tests. The process involves 3 steps. First, the WHO and CDC landscape analysis that has been mentioned previously. 14 laboratory tests will be evaluated as a result of this first step. CDC has recently procured a number of these tests and is in the process of procuring the others. So 2 steps of evaluation are planned. A first evaluation on the intended use of many of these tests, which is for diagnosis of acute dengue infections, and then a second evaluation based on the performance of long-term samples for past infection. All the tests will be evaluated head-to-head with a curated set of PCR-positive samples CDC has selected, and we hope to complete the process by the next ACIP meeting. Cross our fingers. So before I finish, I'd like to share a slide that Dr. Perkins, who presented from the University of Notre Dame's modeling of cost effectiveness of Dengvaxia in Puerto Rico last October, did not get around to showing. This table gives the estimated impact of Dengvaxia vaccination in Puerto Rico over a 10-year time frame for vaccinating 9-year-olds screened by a lab test with 95% specificity and 80% sensitivity at different seroprevalence levels. With a 60% seroprevalence, which is what preliminary data shows for Ponce, Puerto Rico, about 3,800 hospitalizations would be averted among seropositives, and 300 additional hospitalizations would be seen among vaccinated dengue naives who tested seropositive, so a ratio of over 10 to 1. So as always, we'd appreciate feedback with other specific data ACIP would like to see and considerations ACIP would like the work group to cover. I'd like to acknowledge again our work group members, presenters, advisors, and CDC staff supporting the work group. And that's the presentation. Thank you. I do want to just comment on one of the questions that was raised about where laboratory testing would be performed in Puerto Rico. Right now, there are 2 laboratory tests that are CLIA approved that Sanofi has evaluated in publications, which basically show, in their evaluation, 99% specificity. These are available at private laboratories. There have been discussions with the health department of whether they could perform these tests or not, but that's completely up in the air. So I'm open to any questions that you may have.
Thank you very much, Dr. Waterman. Before we open it up for questions, Dr. Rubin will comment on the injury compensation.
Yes. Thank you. Thanks, Dr. Lee, and sorry I didn't have enough caffeine this morning. But so as to your question about the vaccine injury compensation program in Puerto Rico, since it's a U.S. territory, if there are covered vaccines or claims that are alleging the injuries due to the covered vaccines, those will be covered by the vaccine injury compensation program. But if your question is specific to dengue vaccine is not covered at this time. Yep.
Go ahead.
No, Melinda.
Dr. Wharton.
Thank you, and I appreciate that response. One thing that was just occurring to me as I was thinking about this is that if the primary side effect we're concerned about is severe dengue, that hopefully most patients would fully recover from without sequelae, would that be a covered injury?
For dengue vaccine, you said? At this time, dengue is not covered.
No, I understand that, but if it were recommended and the vaccine were included in the program, which I understand it's not now, I thought that the program was designed to address adverse events that had long-term sequelae, rather than something like an illness that might result in hospitalization, but from which the patient would recover.
Oh, okay. So, in terms of, we do have a severity requirement. I think that's what you're stating. In terms of being eligible for compensation, they have to show that sequela has to last more than 6 months, symptoms have to last more than 6 months, or there should be inpatient hospitalization and surgical intervention or death.
Dr. Paley?
Following up on that question is, if the vaccine was recommended, does it matter on the coverage if it is a shared decision-making versus is it fully recommended?
That's a great question. Currently, right now, what's covered in our program are the routine vaccines that the ACIP have routinely recommended for children, and I'm understanding that there's two definitions for routine, but it's the ones that have immune and the immunization tables, not necessarily shared clinical decision.
So I think it's similar to VFC coverage in that if it's in the private insurance coverage, in that if it's on the immunization schedule, it will be included in the vaccine injury compensation program, and it can be either a routine, all children in this age group should get it, or a children should get it based on shared clinical decision making, is in general how it's been done. Is that?
Yes. Typically, it's the ones that have, if they're, for example, meningitis is covered, but it's only a particular age group, but that's for all age group. It's not specific populations at this time, but to be covered, the ACIP has to recommend it for routine administration to children, but there's also has to be an excise task before that coverage goes through.
Did you want to follow up with a question, Dr. Paley? Okay. Dr. Lee.
So you had asked Dr. Waterman what other questions we might want to be asking, and it sort of relates to this conversation, but not exactly, in that the one thing I actually want to just be mindful of is potential disparities in access either to testing or to care that may result. And so my question really derives from the fact that I'm worried about families who may not have the ability to pay for hospitalizations out of pocket, if that were the case, and or other sequelae. So if you could do your best to try and help us with that, that'd be terrific.
Yeah, you've raised that question before, and I think Dr. Escalene would be in the best position to answer that question, but my impression is that access to care in Puerto Rico is quite good. I mean, the large percentage of the population is covered by the indigent healthcare system, and the healthcare system has been compromised by the public debt, but that in general, overall access is good, and I don't know if Dr. Escalene, she's nodding her head. So I think children who have severe illness have access to hospitalization, yes.
Dr. Solange?
Yeah, thanks. This is such a difficult decision. I just am intrigued by the concept of a pilot. So often in system improvement or practice improvement, you do a pilot to sort of work out feasibility issues. What would be really the goal here for the pilot? Would it be taking a subgroup of the population that is insured for which there are no cost barriers? Or can you talk more about what you're thinking in terms of a pilot? What would be learned that then would allow to be scaled up in a meaningful way?
Well, I think Dr. Hambach and I were talking about this a little bit before the meeting started, but I think this is obviously a complex logistical process to undertake, and most of the discussions around pilots have been that there is not a large population, but a significant number of persons who have already had documented dengue infection in the medical record, and that you could start to vaccinate those persons, and at the same time continue this education process and try and solve some of the logistical and insurance issues that have been raised already. So, you know, I think you could argue on the one hand that it would just be sort of a symbolic gesture. It might not have much population impact, but it would get some children vaccinated and maybe could generate momentum towards figuring out how to actually make this a programmatic process if that was the will of the health department and the pediatric
I see.
providers in the
So it wouldn't be so
community.
much a pilot of the lab of this two-step or three-step process.
No, that's not what we've talked about at this point, but I think eventually that part might need to be piloted as well, yeah.
Have you guys discussed about, in terms of doing a pilot, would you need an ACIP recommendation for the specific group of individuals who have previously had documented dengue before conducting a pilot from an economic perspective?
I don't know, not so much from an economic perspective, because I don't think a pilot would have, although there's individual benefit to the vaccine, I think that probably the work group at this point would want to see some sort of ACIP recommendation even before convincing a pilot, though. But I mean,
think
further
that was
discussion is needed on that. Yeah.
And from a
I
cost.
don't know if Dr. Atmer wants to comment on that.
Dr.
Yeah,
Maldonado?
we haven't specifically addressed that, but the discussions that have taken place have been in the context of an ACIP recommendation, and part of the rationale for that is to cover the cost of the vaccine, which is potentially a major consideration.
Dr. Maldonado?
Yeah, Steve, great presentation. Thanks for that. And I think we've come a long way since the original set of discussions. But I do want to revisit at some point this issue of a pilot and what really that means, because it is, as you mentioned, a complex series of issues, not just scientific, but really functional and operational. So building a screening test into public and private sector settings, et cetera, I do think that it would be really helpful to try to pilot that whole, because there will be a series of steps, and depending on the sensitivity and specificity of the test, how do you do informed consent for that? Is it going to be separate, et cetera? Who's going to pay? All of those things, I think a pilot would probably be helpful, because it could be complicated.
Yeah. Yeah, as far as consent, I think that's a really important issue. I don't know if it's informed consent like in a clinical trial, but I think that we need behavioral scientists to come up with good language that's culturally appropriate, that really makes sure that the community understands the risks and benefits, and to sort of have that thoroughly researched ahead of time.
Yeah, and not to take too much time, but so for example, when we rolled out our TLD, rapid testing in labor and delivery for HIV, we did a series. It didn't just roll out. It took a number of, on the ground. They weren't really clinical trials. It was really implementation demonstration projects in the U.S. We're talking about here in this country. And that took a while to get community input, understand how that would really work, engaging OBs and pediatricians and nurse practitioners, et cetera. it took a while to get that all in line before legislation and all that was able to do that in a really, and now, of course, it's seamless generally, but it does take some work.
I mean, even before a pilot, we would need to have considerable education of physicians in the community. So, I mean, that.
Dr. Hunter.
So 2 quick points. One is, I think the main advantage of doing a pilot would be, well, not a main advantage, but one of the big advantages of it would be increasing the confidence of the general public, the pediatricians, and the parents that you got your act together and you're going to do the implementation right. You're going to listen to them. The other thing I wanted to say was that I think that whether or not to do a pilot, if I were in Puerto Rico in the local health department or the territorial health department, I would want to be the people who is deciding whether or not a pilot was done. I would definitely take what the CDC guidance was, but I think that the pilot's going to need to be implemented by the local folks with a lot of support, but I think that they should have the authority to do that personally.
Yeah, let me just comment that the Puerto Rico Health Department is the spokesperson for immunizations in Puerto Rico, and that would clearly happen and would have to happen. Yeah.
Dr. Admar.
Perhaps Dr. Escalene is in a better position to address this, but my understanding of the way the childhood immunization program has worked in Puerto Rico, and in particular, she mentioned the high compliance because of the school requirements. One of the challenges with the shared decision-making is that, and some discussion has taken place, is that if dengue vaccine were added to the schedule, it would be handled like the other childhood vaccinations, assuming the child is seropositive. And while there would be information presented to the family, whether it would be required as part of attending school to increase compliance and to make the system work hasn't been fully decided, but that would be the usual way that such vaccinations would be implemented. And there was some concern in the work group that that could cause problems down the road. But that's my understanding of how it might be implemented were it to be recommended as routine for persons who were seropositive.
Are there any other questions or comments? All right, very good.